Well, good afternoon, everybody. Thank you for attending Career Certs August webinar. We're almost into September. We're so grateful to be here today. We are so very happy to bring you all cutting edge information, state of the art education, and we are remarkably grateful to UT Southwestern and Career Cert for allowing us to have this partnership today. We are delighted to bring you a case that you all, I think you're going to enjoy it. You know how I like kind of twists and turns along the way. And to guide you through it, I would like to introduce you to our panel today. So next slide, Kate, please. First, you have myself. My name is Gil Salazar. I'm an associate professor of emergency medicine at UT Southwestern. I am the section director for EMS education for the organization. I've served as an operational medical director for almost 13 years and an education medical director for 12 years. I am one of the core faculty for our emergency medicine residency program and core faculty for our EMS fellowship program. Some of my interests outside of EMS include modern learning platforms, mentorship, and recently we got our trademark for campus emergency preparedness and survival training. So we're delighted to be here today. Along with me today, I have Virginia Smith. She is one of my proteges, former student. She is a paramedic for Cypress Creek EMS in Spring, Texas. She is now a medical student in Grenada. So Virginia will always be a paramedic at heart, is one of the smartest individuals that I know, and she comes to us by way of Texas A&M. And we are so delighted for Virginia to be here today. And also, we have Dr. Kate Krause, also well known to me for many, many years. I've known Kate since she was a medical student, and now has got an MD behind her name. We've worked together in EMS projects that included, surprise, surprise, virtual learning platforms. She is one of our emergency medicine residents here at UT Southwestern Medical Center now, and she is an EMT basic. She's done some work in the community. So we're delighted for our panelists to be here today. We're going to be trying out a feature that has worked out really well for us the last couple of times. Toward the end in the Q&A portion, if you want to ask a question live, please put it in the chat, and Paula is going to be taking a look at it. If you have any questions during, I'll be monitoring the chat as well. So let's go ahead and kind of set the scene. So next slide, Kate, please. This case, ladies and gentlemen, is actually something that I managed, a case that I managed myself. And this is a kind of a long patient encounter, but it really does begin with EMS. And I really like to take a peek at whenever a case comes up that's really interested, I like to take it from the beginning to all the way to the end. And interestingly enough, this case began by way of EMS as a psychiatric disturbance. That's the way it came through dispatch. The chief complaint was the patient was feeling some sense of anxiety. The initial contact was made by law enforcement at that time. EMS arrived. The crew is 2 paramedics, and by the time they arrived, the scene was safe. We always try to review the conditions at the time of the event, and this was a clear day, good conditions, and all facilities were open with advisory. So we're going to progress through this case, going to take a peek at how this case progresses and how it began. So let's have Dr. Krause tell us a little about the actual encounter itself.
Sure. So show up on scene, there's a 46-year-old male there, and he is feeling anxious. His eyes are darting around. He's got some twitchy movements. You can tell that he's just not having a good day. He's pretty irritable with the staff. They ask him some questions. He's snapping back, but he can be redirected. So with a little of that verbal action there, he calms down a little bit, but you can tell this man's feeling pretty desperate. As they talk to him more, find out he's had some past suicide attempts. He's got bipolar schizophrenia, anxiety, depression. He's on a few psychiatric adding medications. acting medications and no allergies for this gentleman here. So they get an opening set of vitals. We're looking through here. He's a little bit hypertensive, 136/99, but nothing too concerning at this moment. His heart rate is right about where we want it. He's satting well, doesn't need any oxygen at the moment. He's breathing about 19 a minute, so not quite too fast yet, but getting up there. And no fever at the moment.
There you go. So at this moment, we have a patient pretty clear-cut psychiatric presentation, a behavioral health emergency until proven otherwise. We have some hemodynamics that are pretty reassuring for the most part. We have a good sample history from the medics. And when we were looking at this case, we started wondering um, what would we be expected to do for this patient, and a lot of things go into play. So I'd like to learn from you a little bit. So we're going to launch the poll. How would you proceed with this patient? Now we know that there are two paramedics, but do we want to say pretty basic and go BLS only and transport to the closest ED? Do you have in your institution for your agency, do you have dedicated psychiatric facilities, inpatient facilities in your area? Are you allowed transport there? Do you go all out? So we have a patient who is hypertensive. You can make an argument that he is agitated enough and anxious enough, but redirectable. You still want to get him to the closest CD, perhaps start a line. Would you say to yourself, law enforcement is on site, the patient's got a known psychiatric history, he is anxious, he is redirectable? Do you have protocols in your area dictating that the patient doesn't meet transport criteria? We've seen that before. Or do you have mechanisms in place by which police transport the patient as an involuntary hold, as an emergency detention or apprehension by a peace officer without a warrant? So I'd like to learn from you a little bit so we can kind of set the scene. So go ahead and vote. And as we're discussing these possibilities, Virginia, what would be available to you in your clinical area in terms of psychiatric services?
Absolutely. So we do not transport directly to a psych facility, and so that option is out for us. And I think that is smart because we can't rule out medical need and always medical before psych. And even though this patient looks just psych right now, the importance of reassessment is just vital. You have to just keep watching, keep asking questions. So I think we would definitely take him. There's two paramedics, and so by ALS care, but at this point, you could do ALS care, you could do BLS care, transport to an ED, but an ED that you know would have a good psych mechanism in place. You'd get the care he needs. He'd be paid attention to. Just making sure you get that patient advocacy with the transport decision.
So we're looking at our results. Thank you, Virginia. It's pretty interesting to me. Not surprised at all. You know, I am always on the side of keep it simple, and especially with behavioral health emergencies, you're following pretty good guidelines. So BLS care only, transport close to CD. Some of you have the capability to transport directly to a psychiatric care facility, and a lot of you also want to do ALS care. I am totally on board with that. I am not surprised, actually, that very few would choose not to transport this patient. I don't know many folks that would, and definitely getting the patient by police. I think there can be an argument pro or con, though. In my opinion, Virginia learned well. A cause for a behavioral health emergency is organic until proven otherwise. So let's see what EMS actually did. Dr. Krause, let's go to the next slide. So Virginia, take it away.
Absolutely. So this patient did not want to go to the hospital, did not want to go with EMS, and he's in his actions to do so. As long as he's 8 times 4, goes through the protocol necessary for declining. And at the time, law enforcement decided not to detain, and so they got the appropriate signatures, and EMS left the scene. However, they got called back out, and now this gentleman is vomiting. We look at the vital signs again, and they're as shown. And there's twice vomiting. At the time, there isn't any descriptions on the vomiting. It is really important to kind of document what that looks like, because that could give you clues for kind of what's going on. And they decided to do an IV, give Zofran, and transport to the ED. Something to note here, the blood pressure is different than before. Before it was 136 over 70s. It has dropped, but if you look at the heart rate, it's still tacky, and it's even a little bit more tacky. And so that just kind of does a red flag for me of, hey, I need to watch that. What's going on here? Doesn't quite make sense. I can't figure this out right now.
Do we think, Dr. Kraus and Virginia, I'm beginning to wonder, one of the things that I've learned a lot in emergency medicine and EMS is anchoring bias. So we have a patient with a psychiatric complaint. He doesn't want to go. He's a little bit hypertensive. I'm wondering if we were meeting anchoring bias. And so, Kate, can you share with us kind of your thoughts on anchoring bias and how it affects you as a clinician?
Absolutely. Anchoring bias would be when you walk in the room and kind of get a gut feel, okay, I think it's this one thing, and you don't take a step back to say, but, what else could this be? And you go down the pathway of, okay, this gentleman, this is just a psych complaint. And I don't really need to think about anything else because it's clear he's on psychiatric medications. And so that's what I'm dealing with here. But as we're seeing these vital signs change, there may be something else going on here. So I think it's important to kind of ask yourself, what else could this be? Even when it seems like there may be a clear answer. For me, as someone who works in an emergency department as a clinician, I walk in and that's the first time I'm meeting the patient. So in that first 10, 20 seconds, I do have to try to form a gestalt of what do I think is going on today? Do I think something's pretty wrong? But it's always important to kind of take the time to think, okay, what else could explain what's going on?
That's pretty phenomenal. So Virginia, I think the second presentation for the patient this time around, we were recognized that something was going on, and we went ALS with this patient. So one of the first lessons to think about is anchoring bias. And again, kind of the definition of this is kind of hanging on to kind of your thought process. You're cognitively offloading yourself, trying to simplify a situation, and you kind of cling on to that thought. Okay, this is a psychiatric behavioral health emergency, and that's probably what it is. And it turned out that the patient was probably a little bit sicker than we thought originally. And when we got called back out, he was showing signs and symptoms of getting actually pretty sick. So let's go ahead and move to the next slide. So the patient is taken to the emergency department, Dr. Kraus.
Sure. So this gentleman dwells in the ED for about 8 to 12 hours after his initial medical clearance, and then has this new complaint of, oh, I've got chest pain. He's still vomiting. We're seeing this more and more. The patients sometimes hang out in the ED for quite a while. As I'm sure we've all heard this year, the healthcare system is meeting some strain. And so that means that there can be backup all the way through that ED if patients can't be moved in and out. So this is not too surprising to me, unfortunately, but sometimes they have those long times there.
And Kate, there is a reason why, we took the patient to the ED kind of in the prior slide and then moved on 8 to 12 hours later. And so kind of the time in between is actually very interesting. And I wanted to kind of discuss that briefly with our attendees today. There was also a little bit of anchoring bias on our part. The patient is going to report it and verbally hand it off by EMS as a patient who came in with anxiety and then vomited twice. It is not well documented or understood that there were 2 calls for the patient and no documentation of the initial encounter, at which time the patient was hypertensive, really with unremarkable vital signs. There is no documentation of that. So instead, what we get is a patient who calls for anxiety, then calls for vomiting, and we only get kind of really one initial set of vital signs. So this patient, maybe there's a little bit of anchoring bias, had some laboratories which were pretty unremarkable, but it's just really interesting to note that patients spent 8 to 12 hours. There was some anchoring bias on the front end, And then in the middle, there's a little bit of anchoring bias there. He dwelled for around 8 to 12 hours, and then he starts having symptoms. So let's go ahead and take a look at some of the workup that we did do once the patient started complaining of symptoms. So Virginia and Kate, what do y'all think about this EKG?
Well, this is showing sinus rhythm with PVCs. And so PVCs are a sign that there's something going on. This isn't just a normal EKG. We're not worried about it. And so that's the importance of getting a quick EKG, especially when there's a complaint of chest pain, to give us a little bit more of a picture of what's going on.
Yeah, I definitely start to worry when I see an EKG like this. Does he maybe have a metabolic disturbance? Is this patient going into shock? Did he take some kind of substance today? So this makes me start to think, okay, I need to look for something else going on here.
You got to consider things like ischemia, shock, metabolic abnormalities, endocrine abnormalities, DKA, on and on and on and on. So kind of the big lesson that we learned from this EKG, and we changed some of the details within the EKG itself, is that pretty abnormal. And so you take a gentleman coming in with psychiatric complaints, now kind of some nausea, vomiting, now developing symptoms. Now we're starting to get pretty concerned. So let's go ahead and go to poll number 2. Paula, so I want to learn from y'all. What is in your differential diagnosis? What kinds of things do you start thinking about now that he's developed some more nausea, some more vomiting, some chest pain? Before I give you any other information, do we think about the Mallory-Weiss tear, basically an esophagus tear from a lot of vomiting that we see occasionally in patients who consume a lot of alcohol sometimes? Do we think about an MI? The patient is really at an age where non-SC segment elevation MI and acute coronary syndrome can be a problem. Do we think about an aortic dissection? That's mentioned nowhere in the patient's documentation, but all of a sudden you have some very concerning acute symptoms with a change of vital signs that happened 8 to 12 hours ago. Do you think about a pulmonary embolism as well? So what do y'all think might be causing the patient's new symptoms? We discussed the EKG as well with some PVCs, a little bit of a bigeminy pattern on there. So let's start seeing the results, Paula, and see how we fly. Yeah, I'm liking it. Quite a few caught on to the Mallory-Weiss tear party here. Some ischemia as well. Some of you are mentioning aortic dissection and pulmonary embolism. The results of this poll speak a lot to, they really reflect kind of the thoughts of the clinicians at the time. This patient is a little bit of a conundrum, and you can see the differential diagnosis here is pretty wide. It was also very wide in the emergency department. I think people started getting kind of concerned with the patient's presentation enough to get a repeat 12 lead ECG, etc. And so this really reflects to how sick this patient could potentially be. So let's move on to the next one, Dr. Kraus, and let's see what we started doing for the patient.
So this gentleman begins to vomit again as he's awaiting a psychiatry consult. It does get documented at this point that that vomitus is red. So he's transferred to an area that is set up for critical care. He keeps up with that tachycardia. It's persistent even as he's reassessed. And then as people go in and start asking him more and more questions, as they're starting to look for a reason for why he has this bigeminy, that abnormal EKG, why he's presenting this way, they find that he took an entire bottle of black seed oil for medicinal purposes and to control seizures.
I
So
think
this
it's important here to note that tachycardia didn't go away. There's a long time in this whole process, and there has to be something going on besides just anxiety for that still to be there.
Absolutely. And I think this slide highlights the importance of the importance of that continual reassessment, especially when someone has an abnormal vital sign like that. I think it's so important to keep going back, keep looking, because why is he tachycardic? Maybe he's bleeding somewhere, and you'll see him get more tachycardic, maybe develop some pain as you find where that bleeding is. Maybe he's got an infection and you're going to see it get worse. You're going to see him get altered. There are all sorts of pathways that this could go down once you see him have that sign. And just as he's in your care, I feel like it's important to keep a good eye on him.
Absolutely. We have a doctor that works with us at Parkland, and I've gotten to work with him when I was a paramedic, and Dr. Fowler, and he says, always explain a tachycardia. And I think that's just an important rule with every patient.
There is a big reason why we put this slide in here. Number one, this is to honor the great Dr. Fowler, who's one of my mentors, really like my dad in many ways. So always explain the tachycardia, and that is one reason, the main reason. The second reason is um, at this point, I am beginning to wonder. You have a patient who's been dwelling for a significant period of time, who had a change in status all the way going all the way back to our initial EMS encounter. He dwelled for all that time in the emergency department and kind of was getting symptomatic. Now, that red vomit does a little something for me, and it's not a lot. 25 mLs in the grand scheme of things is not a heck of a lot. I'm beginning to wonder if this patient was giving us some signs of getting potentially ill going back to the initial encounter by EMS. Remember, there is no descriptor given for the quality of vomit, and I'm a bit of a stickler for that because you have a patient now with this presentation, with these hemodynamics. In my opinion, he was getting pretty sick. To me, this is looking like hemorrhagic shock until proven otherwise. This is blood until proven otherwise. And now, this was a time in the critical care area where I took over for the patient. And remember, a lot of stuff had happened before my assessment of the patient. But the moment we took a peek at him, the moment we started looking at his hemodynamics, especially the tachycardia, I started getting pretty concerned. I must admit that one of the biggest things that I learned from this case, and we're going to dive into kind of where it goes from here, is the constant need to reassess these patients. That is the third item on this slide that I want you to focus on. We really needed to have a fresh approach to this patient who came in kind of undifferentiated, kind of worsening throughout the course of the day. And I always teach my paramedic students, my EMT students, and my physician colleague in my residence that whenever there is an issue, we need to go to the bedside and ask the patient questions. We need to re-examine the patient. And it was because of this reassessment that we got this history of the black seed oil. And I'll be very frank with you, I had never in my career ever seen a consumption of black seed oil before. I had heard about it before, but I had never seen a patient take it. And to be honest with you, I did not put kind of these two together. So Dr. Krause, walk us through black seed oil and what it really is.
Sure. So this is something I also had to research, and the more I found out about it, the more interesting it became to me. This is a plant called Nigella sativa, and people take the seeds and either crush up the seeds and eat those, or they create oils that extract the compounds from the seeds. Um, and it is used for all kinds of different medicinal purposes. I would find lists 20 things long of things that this Nigella sativa is said to help. And it seems that some of them may actually have some legitimate actions on different parts of the body, but it's typically taken in small amounts. So to ingest an entire bottle is a very large dose of this Nigella sativa oil. Um, and you can get side effects from anything, essentially, any drug that you put in the body. So some common ones for this include allergic reactions, constipation, and vomiting.
I also didn't know what this was, so I also looked it up, and also the dosage, because I didn't have any thought about what an entire bottle meant, and they say take a teaspoon or two a day. So an entire bottle, I would imagine, is a lot more, as you said before. And it was interesting seeing kind of how many things it is used for. Like a couple people quoted it's like the cure for all disease except death, but it seems like they use it is a lot. I haven't heard about it before. Can you tell us a little bit about those allergic reactions, like the mechanism behind that? Is that just like a normal histamine reaction like we see with other allergic reactions? Is it something else? Like what's going on potentially with this gentleman?
Yeah, so anyone having an allergic reaction from this or any other very rare ingestion, I would expect to act similarly as to someone who ate a peanut, and we know that they're allergic to peanuts. So that's going to be widespread histamine release all over the body, and I would expect them to get very similar symptoms to that which we're familiar with, which could be those hives, and specifically the big one to watch out for would be tightening of that airway. So had this man had an allergic reaction or anyone similar to him, we would treat that the same as to say with that IM epi, with Benadryl, and things to that effect.
We're getting some feedback from the audience. They had heard not about black seed, not the oil, but the seed. It's common for certain East Indian flatbreads. That was kind of the extent of my exposure to black seeds, and that is really what I knew, kind of cuisine and maybe some medicinal purposes, but never had I really kind of dived into what it really was. And as I reiterate, at the time, these things were not. Um, I couldn't tie things up. Could this have had something to do with it? It was just a point of interest at the time. So let's learn a little bit about how this specific case and kind of how it unfolds kind of has some implications, Virginia.
Absolutely. So some of the big lessons that I just got out of this is the importance of transport decisions and how you can be a patient advocate based on where you decide to take the patient, or if you decide to take the patient at all. Um, Absolutely, someone's able to refuse, but there's always a hard sell and an easy sell to go to the hospital, and originally maybe this guy should have been a harder sell to go to the hospital. And I don't know what the paramedics did and what they said. So, but that's something to just kind of keep in mind. Like it's not always just psych. There could be something really big medical going on. Also, like the hospital staff tends to vibe off of the paramedics. If the paramedics give a report and it's annoyed, it's frustrated, it's just psych, all that, they're gonna have the attitude too. If the paramedics come in and they're like, hey, I think there's something else going on. Here's why. I don't know, but like take this man seriously. They're gonna vibe off of that. And always the importance of reassessment. And with this, it turned into GI bleeding, the reassessment. It could have been going on for the entire time he was in the hospital. And it absolutely didn't look like this at the beginning, but you need to reassess so that you can see as new symptoms develop and take things seriously as they develop.
Thank you, Virginia. I see a raised hand. I don't know if Lisa Meeks has a question. Feel free to put it in the chat. I saw your hand was raised. Virginia, one of the operational lessons here as we go into kind of what happened with this patient and the GI bleeding. You mentioned this should have been kind of a harder sell, and we don't know exactly kind of what was said or what had happened, or really what the patient might have said that kind of reassure the medics that it was okay to kind of no load the patient. Do you think what aspects of a no load should be absolutely mandatory? Like, for example, some of the things that are dear to me is a second set of vital signs. For example, if you're gonna AMA somebody, refuse somebody, whatever you call it within your system, a repeat set of vital signs should be mandatory. What else do you think should be mandatory for a medic before no loading a patient?
It absolutely depends on the situation. And so first of all, you have to make sure you're safe, but I think just an honest conversation with the patient and going through what could go wrong and what is concerning to me and all the things that could possibly be and how I don't have the ability to test for that right now, but the hospital does. And it doesn't hurt to get checked out. And usually just like the honest, calm conversation tends to work with those that might have been irritable at first, where it looks like this guy might have been irritable at first. It's really important to be someone kind of there with a patient if he really doesn't want to go and he's already talked through all the options and all the concerns. I like to see someone with him kind of watching him, so if for some reason there is going something on that he would pass out, they would be able to call us back if he's not there. Sometimes you can even utilize the friends and family to convince them to not be the hero and stick it out and be rough. Just go get checked out. No worries about that. So those are some of the things that I would look at. Again, that tachycardia at the beginning and how if we saw that develop and maybe the blood pressure changes, if we had gotten 2 sets of vital signs, that would have kind of raised my concerns and therefore my conversation with him as well.
There is also, would love to hear in the chat for some of your systems, whether you have some mandatory aspects of your refusals, your no loads. For example, some examples that I would love for you to give me. Do your no loads have to be recorded on kind of using audio, voice, radio, whatever? Do you record them? Do you have a standard script for refusals that kind of have to be read verbatim to the patient? Is the patient required to speak to an online medical director or a physician, whoever your medical control is? Are they required to do so? So put it in the chat. I would love to see kind of what operational processes you have in place for situations like this in which a patient declines transport. So let's move on over to kind of what is happening with the patient, going back to the medical aspect of it. So take it away, Dr. Kraus.
Yeah, so we think that this gentleman with his vital signs showing that tachycardia, with his blood pressure going down, and with that vomit that was red, was likely exhibiting some signs of an upper GI bleed. And we think that that loss of blood is what then led to those abnormal vital signs. So just a little bit about upper GI bleeding in general. It's most commonly due to peptic ulcer disease, more commonly known as stomach ulcers. And when the blood has a chance to be down in the stomach with all of that digestive juice there, then it changes from its bright red it comes out as into what we would call coffee ground emesis. That person has bleeding in the stomach and then vomits it up. It's going to look more dark, coarse, and a little lumpy, to use a little grosser word. If a patient has underlying liver disease, then the next most common cause of upper GI bleeding would be something we call esophageal varices. That liver gets what we call cirrhosed, and it's a lot harder for blood to move through it. And when that happens, then you get back up to different veins that go around the esophagus itself. So those can pop open and bleed into the esophagus. And then that person would start to vomit more bright red vomit that can be super copious because that liver is what makes blood clotting factors. So if your liver's already not working, you're getting back up to these veins around the esophagus, and then you start bleeding, you don't have a way to clot off those veins. So that's something we think about, especially if someone is coming in vomiting a ton of bright red blood. Diagnosis of upper GI bleeding is often made by what we call an EGD, which would be a camera stuck down the esophagus. I feel like the most important note there is that has to happen at a hospital. So anyone who's showing any of these signs, a coffee ground emesis, a bright red bleeding, for me, those would be, they have to go. Take any convincing I can give them to get them to that EGD.
Absolutely. And I think that also just, again, shows the importance of asking about the vomiting. Whenever I've seen this too, it's been lights and sirens, especially with blood pressure drops like that.
There are a few scarier things in medicine to me, even for the most seasoned EMS professional and physicians too. then a brisk upper GI bleeding that then can turn into hemorrhagic shock, and sometimes even turns into lower GI bleeding as well. When the patient kind of reaches this horrendous coagulopathy, DIC, for example, when they start bleeding everywhere, you lose an airway, and the hemodynamics are so horrendous and so deteriorated that it makes things like airway management an absolute nightmare to manage. So, Dr. Krause, it sounds like this patient had no known history of peptic ulcer disease. We don't think that this was related at all to the medications he was taking or really his psychiatric history at all. There was no history of liver disease, no history of risk factors for liver disease, such as alcohol. And ultimately, the patient did wind up having an EGD. So, does this sound like the black seed oil was at the root, the cause of this patient's gastrointestinal bleeding?
I mean, I feel like it probably was, just given that he hadn't had any bleeding before, and then he takes this Nigella sativa, this new substance, and now he has bleeding. So for me, that goes together. That I think they're related. I was looking into different reasons, the more exact reason it may have caused bleeding. And from what I could see, it seems like this is an active area of research that people are still trying to find out exactly how that Nigella sativa acts on the stomach. And it seems clear that it has some sort of mechanism on the stomach lining, but we're not sure what it is yet. So I'm curious. If I had to place a bet, I would say that those go together, but can't know for sure.
Virginia, do you think they were related, those two?
I don't know. That just seems, if this is a common thing, that seems like an extreme show of symptoms for a common thing, and I don't know what else he's been doing, how, if he usually takes a whole bottle, if this is the first time, if he has other things going on that could maybe make like his stomach sensitive, and maybe this was just like the last straw, or maybe it was just a little bit out of whack and he was kind of already there. But I don't know if it was necessarily just the black seed. Um, but again, I don't know.
It's a phenomenal mystery. Next slide, please,
Yeah.
Kate. The chances are pretty good. This patient had no risk factors for gastrointestinal bleeding, um, reported no GI symptoms on initial EMS presentation, definitely had GI symptoms on the second presentation. Gosh only knows if he had any symptoms on the first one. Um, in my humble opinion, after speaking to some of my toxicology colleagues here at UT Southwestern, kind of ongoing research, even though this is touted as a good medicinal, perhaps even anti-inflammatory, may have the complete opposite effect on the stomach lining. And so this is kind of the one variable that kind of kept popping up. So I wanted to kind of emphasize that whenever we're getting a history and a physical exam from patients. Granted, this was probably a very difficult history to get initially, especially since he was so anxious, maybe a little agitated. It just brings up the concept of we need to be very watchful and reassess these patients and don't stop asking the important questions. Um, Now, as I mentioned earlier, there are a few things in medicine that are so that are more scary than a bad upper GI bleed for several reasons. And so I wanted to discuss with you a little bit of a feasible, sensible approach to upper GI bleeding. First and foremost, as the next generation of EMS professionals is kind of going through, more and more attention is paid to video laryngoscopy. Um, Many of our existing medics, many of you here are using VL for as your primary airway visualization tool, as your primary laryngoscope, and you and I know that the visualization of a bleeding airway is superbly difficult many times with a video laryngoscopy approach. So to that end, one of the lessons for today is I would really urge your agencies to begin considering training, not just for difficult airways in which we're having trouble mechanically visualizing, but also the management of visualization that's poor as a result of fluids. To that end, there are several different approaches, such as the soiled airway laryngoscopy, or the salad, as we commonly refer to it, approach, in which you use a very advanced way of using your suctioning to be able to visualize your airway a little bit better. Dr. Kraus, they're using this fancy approach, this very aggressive approach. Sounds kind of pretty aggressive and a little tough. Can you talk to us a little bit about kind of your mental preparation for a difficult airway and visualization when you're having this specific case?
Sure. As I would look at this case, I'm thinking, okay, this gentleman is vomiting blood. I need to be ready for that blood or any other secretion to be in my way as I'm trying to find the cords. And so as I'm taking a look, I'm wondering how much blood is there? Is it still coming out? Is this an active vomit, or has he calmed down for a minute here as we're looking to intubate? And I'm definitely thinking about suction. I need a way to get that blood out of my way as soon as possible. So leading with suction, I think, is definitely not a bad call here, to make sure that you're not delayed while you try to find your way around.
Having unlimited suction canisters in a very fancy critical care area sounds phenomenal. Now, Virginia, you who have practiced in the field for a long time and you've been in this situation, is this a feasible approach for EMS, this aggressive suctioning approach? Can we get away with something like that in the field?
Yeah, I mean, just we have suction, we have portable suction, we have suction in the ambulance, and I suction before any attempt at the airway, and have it there and ready and there if I need it again. And so in even teaching new paramedics how to intubate, that's just drilled into us, like you need to have your suction there available and it needs to be used first. We can't go as aggressive and we don't have all the tools that an ER has, but we thankfully do have suction. And I would think that every agency would. And I think that definitely needs to be the first step, and used aggressively and used well.
The concept of suction has really evolved over the last, I would say, 5 years or so, and everybody has suction. How we utilize that suction has gone through a very awesome evolution. So Dr. Kraus mentioned leading a epiglotoscopy approach using suction. How crazy is that to actually put a suction catheter perhaps in the esophagus and begin to suction that out before you go ahead with your laryngoscope. I would really urge all of you to consider these revolutionary very helpful airway algorithms and in courses, because when it comes to a soiled airway, especially with fluids, vomit, etc., it can definitely make your life quite a bit difficult. So the second point that I wanted to bring up is that even once we've taken care of the patient and delivered them to the hospital, remember that we mentioned earlier Mallory-Weiss tears. There's also something called Boerhaave's syndrome, for example, and the injury to the esophagus as a result of profuse vomiting, which appeared to be a real problem in this patient, is esophageal rupture, which can lead to inflammation of the mediastinum. And mediastinitis, as we refer to this condition, is can be absolutely catastrophic. You can imagine vomitus entering all those areas surrounding your in your chest, in your trachea, your heart, your lungs, and just soiling that with acidic contents or irritants such as blood. And so these patients can be remarkably sick. You may run into them already when they are in complete hemorrhagic shock. They can be in septic shock as well, or they can look actually relatively decent, maybe complaining of some shortness of breath and some chest pain. But I wanted to get kind of some of these, this other end of the spectrum in the back of your mind when you're thinking about the patient with GI bleeding. Is not just about the fluids and the losing of blood. It's actually kind of the mechanical and structural damage that these conditions can cause. Wanted to address a question. Thank you, Megan. She asked, Megan wants to know, does the patient have anything lower down in the bowel? And Megan, great question. Thank you so much. And EGD only reaches the level of the stomach and kind of this beginning part of the small bowel in the duodenum. The patient did not go a colonoscopy on the other end, down below. Phenomenal question. It would be very interesting to see, can the black seed oil also cause downstream effects on the lower GI? So that's if you get the question from that, please let me know. I wanted to address, I mentioned earlier, I wanted to see in the chat about refusals. And so I really like a lot of the comments that I saw here. So thank you for those. What I was seeing here is that there's a lot of you, you don't record them, but you do expect a full set of vital signs, including a glucose, and you have specific protocols in place. Yeah, and including documentation requirements. There may not be a lot of documentation for you, but there are documentation requirements. One of the most interesting ones that I saw here is, and I'm glad this mentioned, this attendee mentioned, but the rise of mental health responders has really kind of taken a hold. And for those of you who haven't heard of this before, for example, we have it here in Dallas, is when you have patients with a behavioral health emergency, a team that includes EMS sometimes, mostly law enforcement sometimes, and a mental health professional can respond to scenes that meet certain criteria. And so that has been a phenomenal addition to patients. As we learn more about behavioral health emergencies, I think the rise of these multidisciplinary teams are going to make a big splash in the EMS arena. Dr. Kraus, um, we have the advent of these multidisciplinary teams. What do you think a mental health, a social worker, or a psychologist, for example, what do you think these individuals add to the mix in these complex behavioral health emergencies in EMS?
I think they add so much to the mix because these are cases that take a lot of coordination to handle appropriately and look out for the patient. And a lot of times these patients are ultimately going to need resources, either a place to go, someone to make sure that they have help at home or what have you. And so having these other disciplines on board, I think can only lead to great things for patients in terms of making sure that their mental health is taken care of.
In Virginia, we are also we have also many areas, many EMS agencies in the United States and beyond have begun to train law enforcement in the management of behavioral health emergencies. So much so that, for example, the term excited delirium is not is less preferred now than it used to be, and we prefer to call it kind of have a more clinical, a more medical component to it, and we call it a behavioral health emergency. So what aspects of training do you think a law enforcement, a police officer might need to learn, like de-escalation, for example? What other aspects of training do you think a law enforcement officer might need to learn?
I think de-escalation is a huge one, and thankfully in our area, our law enforcement is incredible and works really well with us, and we work really well with them, and it's just a smooth team in approaching some of these behavior emergencies and some that have even been escalated by the patient. It's just been incredible to have them work with us and do so well. I think a good tool is when to recognize when it like how to recognize it's medical, it's it's escalating, what's safe, what's not, how do we approach this, just kind of the next steps. Just like when we are looking at a patient and have to recognize, hey, this is when we call a supervisor. I think that recognition is really important too, and that's kind of hard to do. But I think it's definitely really important.
Well, thank you so very much. We're about 9 minutes away. Um, let's open it up to any questions that folks have, and please put them in the chat if you want to ask a question live. This would be a great time to put it in there, and you can ask us anything that you wish. While we're waiting for for questions, I wanted to kind of summarize the case a little bit in some learning points. Number one, we had an initial call for a behavioral health emergency, mostly anxiety. The patient presentation at the time was probably unimpressive. The patient did not want to go to the hospital. There was no medical or legal criteria for an involuntary hold for the patient on or emergency detention. So the patient actually declined to be transported to the hospital. The second call was for nausea, vomiting. At that time, there was a change in vital signs. The patient's blood pressure was lower. Now there was tachycardia, and the patient was transported to the hospital where there was kind of a prolonged period of time in which the patient had been relatively stable until he began to have chest pain and more vomiting. This time it was red vomiting. This time the patient was tachycardic. The patient was taken to the critical care area where a secondary assessment was made, a secondary history was taken, and the patient admitted to taking black seed oil for medicinal purposes. The patient was treated like a GI bleed, and which really didn't yield any other findings other than kind of what you saw here. So to me, it was just very impressive how this patient went from really relatively something minor, a psychiatric issue, all the way to hemorrhagic shock. And then on top of that, you have this substance that I'd only heard as part of a cuisine. So, Virginia, what is one lesson that you would want to impart if you had a student today? We had several pearls. What would be something that you may want to teach them?
Just those psych patients. As frustrating as sometimes they can be, don't write them off. Be a patient advocate, do thorough reassessments, continue to talk to them, and always assume medical, never just write them off.
100%. Joe Stellwagen, thank you for your comment. Joe says the patient likely did not have any signs of trauma as a potential cause for his change in vital signs on that second EMS call. This category of patient is at risk for lots of problems, including abuse. Joe, that's a phenomenal point. So, Kate, I'd like to see if you would like to address Joe's comment. This patient being at risk for kind of psychosocial issues, including trauma and abuse.
Absolutely. I think that's a great thing that you pointed out there, because these patients may not open with it. They may not have you come in and say, hey, I'm being abused. And so it's something that's really important for us to keep in mind and look out for, especially patients that have an underlying psychiatric diagnosis, patients who are older, patients being taken care of by others. I think it's important to keep a lookout for that. And that may be a time if your mind kind of gets clicked off like, something's not right here, even if you can't really lay a finger on it, I think that's a really good time to push for that patient to be transported, because once they get to the hospital, then there are more people that are going to look into it, and they may be able to be provided with resources to try and get them out of a situation that's really bad for them.
Yeah, absolutely. So we're nearing the end of our presentation. I'll leave my leave you with this last thought. We've all been going through a really tough time lately. Both EMS and hospital-based personnel, and sometimes both. Those of you who work in the field and in the hospitals get the double whammy. And I want to reiterate that EMS is part of the House of Medicine. We fought very, very hard to bring EMS into the House of Medicine. Many folks said it couldn't be done. And then very quickly, our communities realized that our out of hospital personnel were capable members of the House of Medicine, capable of delivering cutting edge, compassionate medicine. And now more than ever, this is a time where we have to stick together. This is a time where we can really truly make a difference in how this pandemic goes. So I just want to let you know I see you, I support you, and if we're gonna get through this, we have to let go of our differences, of our own biases, our own insecurities. Otherwise, we run the risk of the House of Medicine being fractured. So I send you lots of greetings, and if we can do anything for you, please let us know. Thank you so much to Career Sir for having us. Thank you, Virginia. As always, I am so proud of you and joining us all the way from medical school, which is amazing. Dr. Kraus, I am so incredibly proud of you for all the work that you've done as a medical student and now as a resident. It's an honor working with you. Thank you, Paula, for allowing us to be here today. And Paula, I don't know if your sound is better. If you wanted to mention the CE portion,
Yes, let's try. Can you hear me?
I can hear you. It's a little quiet, but I can hear you.
Okay, I don't know what's going on, but I'm glad you can hear me. Just wanted to thank you, Dr. Salazar, Virginia, and Dr. Kraus, everyone else for joining today. I just wanted to mention you can visit us at careercert.com always, and you can find more webinars there, free resources to help you prepare you to improve patient outcomes. And I second Dr. Salazar's words. Thank you for all that you do for our communities. And just one last comment. If you would like to earn free CAPC accredited CE hours for attending this webinar, please complete the assessment that we will distribute to you. You will be getting it in your email in the next 48 hours so that once you complete the assessment, we will automatically report your CE hours to CAPC. Thank you everyone for joining today.
Bye, y'all. Thank you so much.